in the question box. Okay, so it is now with great pleasure that I introduce Dr. Alan Percy from the University of Alabama at Birmingham. He's going to talk to us today about factors affecting longevity, and he is speaking from a place of deep, great expertise. He has been a good friend to our Rett syndrome family for decades, since the very early days of Rett syndrome being known in the United States. And he is also lead PI for the natural history study. So he is coming from a place of statistics and data, but also from his long-term experience, observation, and relationships with family. So with that brief introduction, Dr. Percy, if you'd like to go ahead, I'll be happy to advance your slides when you're ready. Just give me a cue. Okay. Everybody see the slides now?
Yes. So for the next several minutes, I'm going to be talking about the many factors that affect longevity. I have gone through these and jotted down some notes as well, and hope that I cover every point. And I think that at least in terms of some of the questions that were sent out on the left-hand column of what I received, this presentation will answer many or maybe most of those questions. So if we could go to the next slide. So just in general, longevity has been increasing in inherited and developmental disorders over the past several decades. When I was in training, which was quite a while ago, disorders like Down syndrome and cystic fibrosis were very difficult to manage, and individuals with these disorders rarely lived beyond age 20. But in the past 60 years, this has really increased significantly. And what are the reasons for that? Some of them are the changes in medical management. There were certain surgeries that were often required in Down syndrome that were not often done. And in the years since 1970 or late 60s, those surgeries have been routine. The particular surgeries for Down syndrome are repair of heart defects and also repair of gastrointestinal blockages. For cystic fibrosis, it's been a relatively constant advance of medical treatment for these individuals, better antibiotics, better overall care, and better nutrition, so that many individuals now with cystic fibrosis are living well into middle age. Same is true for Down syndrome. And those with cystic fibrosis have actually been able to have children and go through the rigors of pregnancy, which I think many of you can relate to. That's not necessarily an easy process overall. So better longitudinal care, better general health guidance, and better services, both within the medical community, but also within the schools, within the public services that are available to individuals with developmental or inherited disorders. Go to the next slide. There are also many trends in health maintenance that have improved dramatically. We now know that for many disorders, including Rett syndrome, it's essential to do routine blood work, to check x-rays, particularly for scoliosis or joint deformities, particularly in the hips or the knees, and electrocardiograms, which are really important in Rett syndrome for many individuals with this disorder. Also, nutrition has improved, not only because the population is better able to provide for their children, but in addition, there's more science related to what it is one needs to take in adequately to maintain proper weight, or on the other hand, particularly could affect individuals with Down syndrome, is sometimes these children and young adults take on too much weight. And it's important to be able to regulate that as well. We see the same issues in many girls with Rett syndrome. We have had markedly improved therapies available both within the school system, but also available through private sources. And in particular, there are programs now for children with delayed development beginning already in the first or second year of life, before school is even begun, so that the need to support these strictly out of insurance is really not present. The problem, one of the problems with physical and occupational therapy is that when your insurance policy allows you to have those kinds of therapies, they're limited in the overall time because one is expected to improve with whatever the disorder is, whatever the problem is, with physical and occupational therapy. And for disorders like Rett syndrome, of course, we're looking to improve things, but we're also looking not to lose skills that have already been acquired, and that's definitely a problem. The communication therapy has advanced greatly, as well as the training of individuals who provide communication therapy and the more high-tech communication devices that have become available over the last 10 or 15 years have been remarkably effective in getting the attention of girls with or women with Rett syndrome. And the availability and improvement in orthotics has been greatly effective in maintaining normal position and posture of the extremities, particularly the lower extremities in individuals with Rett syndrome. We also are able to recognize and detect causes of aspiration. That is certainly a significant problem in some individuals with Rett syndrome, and it's important to be able to assess this adequately and effectively. I would say back in the 60s and in many places, right up through the end of the last century, there was often a reluctance among surgeons to proceed with certain orthopedic procedures. In particular, in Rett syndrome, it's scoliosis, but gastrointestinal surgeries as well, or things like G-tube placements, stomach emptying, gallbladder disorders, and so on. And I guess the final point that I would make on this is that of vaccinations. I know this is often a difficult subject to discuss and to hear, but we are firm believers in immunizations and vaccinations. When I was a child, this was never even heard of. But now the wide range of immunizations is safe, it's easy to obtain, and it's relatively pain-free or disability disorder-free. In particular, we are concerned about the annual flu vaccine. As the virus for flu changes because it's a rapidly evolving virus, and so the immunization changes. Now, the immunizations that are available are based on, for next year, are based on viruses that are obtained during the present time, because it takes some time to create these vaccines. Nonetheless, even though they may not be perfect, they certainly can improve the likelihood of having no disease or a much milder disorder. Similarly, the Pneumovax is available. That was not even considered when I was a child. And there are many other immunizations that are currently in use and should be used regularly. I understand that there are certain groups in the population who speak against these, but there is absolutely no scientific evidence that these immunizations have bad effects and produce disorders such as autism. Next slide. So longevity in Rett syndrome. What are the factors that have changed this? There's earlier recognition. When we started the natural history study in 2006, actually began gathering information. We had individuals of a wide variety of ages, and so the average age at enrollment was 4 to 6 years of. Currently, that average is now under 2.5 years. We saw a young girl yesterday whose birthday, second year birthday, will be tomorrow. This is simply because there are multiple factors. One, physicians are paying attention to developmental delays, and two, rather than having to do a specific gene test for each disorder, there are now scans that can be done either on the whole genome or exome or on a panel of disorders relating to, for example, neuromuscular issues or seizures and so on. So the earlier recognition allows us to make recommendations and to guide families in their care for a much longer period of time. There's also earlier intervention. So whereas before, many times operations or surgeries for scoliosis was put off until the girls were substantially deformed. Now, when the level of scoliosis reaches a certain extent, 40 degrees usually, and considerations for surgery and conversations with the family are actively engaged. And similarly, things like G-tubes. You know, we often did a G-tube at the very last resort. Now, if a child is having issues with swallowing, eating effectively, maintaining weight in an appropriate way, we jump right in. And we have surgeons here who understand that, and there are similar surgeons throughout the country. And from a personal or family point of view, the information explosion has been tremendous. You can look things up on the internet and be almost as versed in Rett syndrome or other disorders as we can. It's all out there. Sometimes you need medical input to decide what is right information and what is maybe not so right information, but the information is out there, so that we have had a number of families who have gone to the physician and said, I think my daughter has Rett syndrome or related disorder. The second part or the third part has to do with adulthood. You know, this is a difficult period because the services that are widely available through schools tend to end at age 22, once the child passes age 21. And those services go away. So it's the development of services in the community that allows for after school care and perhaps services that can improve their socialization and interaction with others. Another factor is the difference between home care and assisted living. In this country, when we last looked at the data, and it was only a year ago, the vast majority of individuals with Rett syndrome, regardless of age, live at home. Now, this is more than 95%. Other countries in the world are not anywhere near that. And personally, I think the care that is derived at home by parents is still superior to that one can get in an assisted living facility. The events of increasing age, and I've mentioned one, is the lack of services. That's important to pursue any opportunity or avenue in your community to find some place where your daughter can go and not be just there for custodial service, but also can have various interactions or therapies to continue. Also, once a girl reaches maturity and her siblings, if she has them, can go off, I better go back to the last slide, can go off to school or employment or the military or what have you, then the socialization with age-matched peers, including the ones they went to school with who are also often doing other things, that decreases dramatically. And we have seen time after time evidence of depression, internalization or withdrawal of girls with Rett syndrome when these things went away. Another thing that we have never written about, but we have made at least observations, and that is that girls with Rett syndrome appear very young. We have multiple girls that we see who are in their late 20s or 30s who look like they're 20 or less years of age. However, beginning after age 30 or 35, there appears to be some acceleration of aging. There is a slowing down of movement, getting around, and there is also, there are certain physical signs which may or may not be true, but we certainly have taken notice that many of the girls have, for example, premature graying of their hair or color change. Next slide. So, what are the historical trends in Rett syndrome? Unlike Down syndrome and cystic fibrosis, Rett syndrome is a relatively young disorder. It's only been described for 55 years. It was probably first seen by Andy Rett and by Bengt Hagberg in the 50s, but not written about widely until 1983, and that's when most of the people in the US became aware of it, as well as other people throughout the world. And I have had the opportunity to see girls and women in both populations, that is, both in Austria and in Sweden. And I was often struck by the degree of physical deformity that they had without any effort or evidence that therapies were involved or even surgeries. So significant scoliosis, deformities of the extremities with contractures, dystonia or abnormal positions were quite prominent or prevalent during that population. And this has changed over time. In the US Natural History Study, we started out right away gathering information on longevity. We used a statistical curve that is commonly used in the insurance business or in financial businesses called Kaplan-Meier, where you can project over time how the phenomenon is going to develop. So we had initial study dating back to 2008 with Russell Kirby, and then multiple subsequent studies with Daniel Tarquinio, where we have shown markedly improved or extended survival in individuals with Rett syndrome. Now, many of you know that in the natural history study, we also do look at males who have mutations in MECP2. Many of them do not have Rett syndrome per se, but they do have significant developmental and cognitive issues. However, in the boys, the presentation is variable, very variable, from young males who have difficulty breathing and require intubation and a mechanical ventilation in order to survive, all the way up to boys who have mutations in MECP2 and have relatively minor cognitive delays, but no particular physical abnormalities, and quite a variation in between. We made a presentation, I think about 17 or 16 months ago, in which we described a paper that we'd written involving 31 males with mutations in MECP2. After that presentation, we became aware of a substantial number of boys that, for a variety of reasons, we had not seen, and they would not be able to travel to one of the clinics. And we have subsequently worked out a mechanism for doing remote visits. This has been somewhat slowed down by the COVID experience and also by delays in getting approvals to study these boys in this way. But we are beginning to gather more information. And in addition to boys with MECP2 mutations, we are looking at individuals with duplication of the MECP2 gene, CDKL5 and FOXG1 disorders, which are similar but decidedly different from Rett syndrome. We do not have enough information on any of these three disorders to make any conclusions about what their survival is likely to be. Next slide. So going back a bit, what are the secular trends that affect Rett syndrome specifically? I've already mentioned many of these, but we'll just go through them. We have an improved nutrition. We recognized in the 90s that when a girl has not gained any weight for 6, 12 months, then it is time to intervene. And the reasons for not being able to do this is the GI system is involved in some girls from the top to the bottom, so that they really cannot adequately manipulate food in the mouth. Their esophagus doesn't work properly, and the stomach is delayed in emptying. And in addition, there is gallbladder and dysfunction and constipation. Gallbladder dysfunction is relatively less common, but it still can be a significant issue if all of the others are ruled out. So that we now have medications to look for GI reflux, gastroesophageal GE reflux. If needs be, if there is evidence that the child isn't swallowing properly, we do swallow studies, different degrees of liquidity of the food to see if there's a problem with one kind of food or another, or if there is, it makes no difference, they cannot swallow adequately. In that case, then we go to a G-tube, generally with fundoplication. That is to make a little purse string around the esophagus to reduce the reflux back up out of the stomach from the G-tube placement. Now, this fundoplication does not mean that you cannot vomit, or if necessary, you certainly can. It's just more difficult to do it. Delayed stomach emptying is also a problem, and that can be managed with very simple old medications. And then we know from a study done by Kay Motil many years ago, the number of girls who have issues with constipation, which may approach 80 or 90%. And then the gallbladder. So, and this could happen at any age. Perhaps it's more common as the individual's age, but it can happen as young as 2 or 3. And so if the girl is complaining of that makes you think she has pain, and you've ruled out the reflux and constipation and delayed stomach emptying, then there are special tests that you can do to look for gallbladder dysfunction, such as an ultrasound to make certain the gallbladder does not have stones, or then if that's normal, you may need to do a functional study, which is called the HIDA, H-I-D-A, all caps, scan. That tells you whether or not the gallbladder excretes bile properly with a higher fat diet. Then I've already mentioned the treatment for scoliosis and joint deformities. That is now done much more commonly and more easily. So in our studies over time, initially we found that 13% of girls with Rett syndrome had scoliosis surgery. And the more recent publication, the number is almost 20%. And it's real, and most of the parents that we have surveyed have been remarkably positive about the outcomes of the scoliosis surgery. Then there's certain issues with adult treatment. Many times internists have a problem taking care of these unusual disorders that were typically seen by pediatricians, and then when they come to adult physicians, they really don't know what to do. But we have a very simple message. You don't have to worry about Rett syndrome. We can handle that. You simply have to worry about the ordinary medical problems, the prevention and the care that you would do in any adult. In particular, in Rett syndrome, it's important to include gynecologic assessment. Now, these women are not going to be sexually active, so there's probably no need for a speculum exam, but certainly an ultrasound of the ovaries and a palpation feeling of the ovaries and the uterus is very important. It can be done relatively simply and without essentially adding any pain. Next slide. So when you look back at Andy Rett's original group, and this was done in 2010 by Michael Freilinger in Austria, as well as colleagues from Australia. And they noted that the median age of death of the 22 or so females was nearly age 14. 3 of the 22 were still alive in 2010. I have no knowledge of how they have survived since. On comparing that to the Australian group, the probability of living up to age 25 was only 21% in the girls with Rett syndrome, whereas in Austria, whereas in the Australian group through the current time, it was 71%. Next slide. Now, I noticed that some of, or many of the questions asked were, what is known about the cause of death? And much of this is speculation, because for the majority, we simply do not know. It's because the girls die suddenly. They either die in their sleep or when they're unattended during the daytime, such that it is unclear what happened. We have presumed that it could be related to seizures. It could be related to aspiration leading to pneumonia. The aspiration could occur during a seizure or occur separately from a seizure. There is also the problem of the prolonged QT syndrome, which is seen in a relatively small, less than 20% of girls with or women with Rett syndrome. But it is a phenomenon that we have known for the past nearly 30 years. In that when you look at the ECG or the EKG over time in these girls, there is a general trend to some abnormalities in the T wave function, as well as the QT interval. The QT interval in milliseconds, the normal value is up to 450 milliseconds. That if that QT interval extends significantly, then the heart, which beats automatically, may forget to beat again. But that's with QT intervals that are more than 600 milliseconds. So the range between 450 and 470 or 80 to a cardiologist, that's questionable whether it's abnormal. Beyond that, then there is concern. And the cardiologists here and many places have used a beta blocker drug, such as propranolol, Inderal is a trade name, or related compounds to bring the QT interval back to normal. We have seen 2 or 3 girls who have QT intervals greater than 600 milliseconds, and at least 2 of them had pacemaking devices inserted, such that if there is a delay in the QT interval, then there would be an automatic signal for the heart to contract. The one factor has been brought out, not by us actually, but by Volker Hannefeld in Europe, was the remarkably low number of cancers defined or described in children or individuals, older individuals with Rett syndrome. We have not done any systematic study because you can't do that really in the US because we don't have a single payer or national health service. But it's just remarkable the low number of cancers, including leukemia, that we have seen in children. Now, the last couple slides that I have deal with the actual data that we have on longevity. So you can see on the left-hand column the age in years and the survival on the right in this chart. So through age 10, survival is relatively normal. Through age 20, the survival is down to 90%. And by age 50, the survival is still greater than 50 years of age. Now, of course, this is not normal because in the typical female population, the survival is up to age, sorry, I had a text come in, 80 years of age. So it's less than normal, but it is still remarkable. Remarkable because if the daughter or your daughter is over 50 and you are older by considerable period and maybe having difficulties in your own right caring for someone of that age and size. Therefore, sometimes other members of the family, we have one woman who's over almost 60, who is cared for by her siblings. They kind of rotate responsibilities throughout the year. So the survival is at least double what was seen in the Andy Rett's original group. And the next slide breaks this down further. These are data that were actually generated and not published, but generated by Jeff Newell, which compares the age of individuals in the Kaplan-Meier curve with the clinical severity score. And you can see that those with milder scores have a quite good survival up to age 50. Beyond age 50, we don't have enough numbers really to compute this. And you can see that by the mild and the intermediate affected individuals have a similar level of survival, whereas those that are more severely impacted still are above age 60. I'm sorry, about age 60% of survival. And the last slide, I tend to show this simply because this demonstrates what can happen to a young woman who is given the best of care, has associations both with her parents, but also with age-matched siblings or friends. This is the first girl I saw in Houston back in 1983. She is now over age 40, and she does extremely well. Now, Jeff Newell has criticized me, jokingly, that I'm showing a picture of a Rett syndrome girl in a bar. Well, you know, she is 40, and she can certainly go to a bar as any other 40-year-old can do, or 20-year-old. And it simply points out the benefits of involving your daughters in normal social events throughout their lives. So I will stop there and try to answer questions as best I can.
Great. Thank you so much, Dr. Percy. I'll come back on with my webcam. that's going to come up. And we're going to stay resting on this beautiful slide of Ashley, because I think she is a good friend to all of us. If you're on social media, you know the Fries, and they really are a model family who's been involved with our community for a long time and shares their journey openly. So I think this is a good resting place. Now, I know that we have to cut the webcast short today because your clinic schedule has been disrupted. We are all experiencing a lot of wrinkles in our planned time due to COVID and whatnot. So we really, really appreciate you taking the time today and pulling together these statistics. They are really hopeful and show a lot of promise at how we have changed the curve on longevity for individuals with Rett syndrome, both females and males, and with other disorders. So I hope that that is the most encouraging message that everybody takes away from the call today. We do have a few questions that were submitted in advance. Well, we have a lot of questions that were submitted in advance. We don't have time to get to all of them today. Not all of them were directly related to the topic on hand today. Most of them were directed to you about your expertise. So we'll take those offline, but I think there are some that you touched on in your presentation that are that bear repeating. So if we can just re-emphasize some of these. The majority of families came to the presentation today really thinking about causes of death. And as a parent of a teenager or a young woman with Rett syndrome, I'm very sympathetic, empathetic, and can relate to those concerns. All of us read stories about children who pass unexpectedly in their sleep, and we all want to know if there are things that we can do to prevent that issue. So that question was asked quite frequently because I think parents really have a lot of concerns about what happens in sleep that we can do to control events that might happen. Do you have anything to share with us in terms of advice?
I'm not a sleep expert at all by any means, but there are certain things that can happen, particularly when your daughter is in a recumbent position, as in sleep. And such, some of these, one is reflux. They certainly have a greater chance of having reflux. I myself, when I lie down at night, sometimes I have heartburn. That's reflux. And it depends, obviously, or in general, on what I eat. But you need to be cognizant of the potential for reflux and to be alert to any signs. So if you see spit up on the pillow or the sheet, if there's drying of debris around the mouth in the morning, yeah, that's a good clue, and maybe something that either your physician, general physician, or your a gastroenterologist needs to have a look at. There are certain things you can do to prevent or alleviate the problem. You can raise the head of the bed, either by putting blocks under the bed or have a wedge-shaped pillow or under the mattress that elevates the head of the bed. What about her breathing during sleep? If you notice that she holds her breath or has periods of breath holding, ordinarily we don't see that as frequently as during wakefulness. But if that is occurring, maybe you need to have a sleep study and then figure out what is going on when she is doing this during her sleep. There is so-called obstructive apnea. That's usually when you have a lax pharynx, closes down, or maybe in a younger girl, when the tonsils are big, it's in the way. And so there are certain things that can be evaluated if the sleep study does show that. and it'd be worthwhile having a visit with a ENT physician. The question often comes up, should we have a monitor? And I go back and forth on the value or lack of value of a monitor. If you start paying attention to the monitor and not pay attention to your daughter, I think it's going to drive you crazy. So one alternative is to have a camera system in the room with linked to your bedside table, and you can hear her breathing, or if she stops breathing, and that can be I think easier than listening to a chime going off periodically. The chime can go off for reasons unrelated to breathing. Maybe it gets disconnected. Maybe the batteries run out. I mean, there are just a number of things that can wake you up and distract you, and really are not real problems. I think those are the main things that I tell people to watch out for. By and large, we have not had major issues here with that. We just haven't. I guess we manage them prospectively, and so the problems don't crop up. But again, it's a question of being alert and having a good physician who listens to you and pays attention to what you say.
Thank you. Thank you very much. That's a lot of really helpful advice. And we do encourage families to try to relax into that issue, not be too concerned. It can create a lot of anxiety and a lot of fear, and your health always is directly tied to the health of your children. So if you're not getting good sleep, this is my advice to parents. Sorry, Dr. Percy, I'm going to jump in here. That if you yourself are not getting good sleep and taking care of yourself and are really becoming preoccupied with anxieties and fears, it is going to affect your ability to take care of your child. So take Dr. Percy's advice to heart, please, especially in this day and age where there is technology that can assist you so that you can get a good night's sleep in your own bedroom. And we have had a RettEd on sleep by Dr. Glaze. That recording is available on our website, and you can access that recording, and he talks a lot about issues of sleep, how to get our girls to sleep, stay asleep, and sleep safely. So thank you for that. Okay, in the last few minutes, I'm going to summarize a trend of some of the questions. Now, one of them is, well, first, I'd like to thank all of the parents who wrote in and said, my daughter is 37, 44, 55, 57, 60, and she is better, healthier, more engaged than ever. So despite, say, a surgery early in life for a G-tube or a scoliosis, a lot of our parents have written in and said that as women, and they are finding that their women are improving with life and with age. And I think that is just a really wonderful thing to hear. So that doesn't really require comment, but I think it is should be acknowledged. Now, Rett syndrome being a spectrum disorder, we also have another set of parents who have said that as their children have aged from childhood to adulthood, have seemed to experience a lot more things like tremor. And you talked about that a little bit earlier, as well as cognitive decline. So girls who maybe have grown into women, boys into men, that as they age have seemed to become more confused or maybe not as engaged with their environment. So can you address those things? Are they medical issues? Are they to be expected in aging? Is there an intervention that families can do as they start to see those kinds of changes?
Yeah, so there's not any single answer to this. I must say that what we have seen in women as they grow older is they move less. And that's probably related to some motor issues. So typically these girls have low muscle tone during early childhood. As they grow older, their muscle tone actually increases beyond normal, and they may have a level of rigidity, less flexibility in their extremities that really slows down their movement. I know there's a question here, is there a later regression? We don't regard that as a regression necessarily. It's simply a change in their physical abilities. It's not suddenly they were moving and then the next day they're not moving. It's not a sudden regression, just a change in the medical picture. In addition, we agree, and we have seen greater numbers of movement disorders with aging, such as tremor, things that are called myoclonus or myoclonic jerks, which are sudden jumping movements of one or all extremities. There are medications that can be introduced in these cases. You need to see a movement disorder expert, which is a neurologist, typically. And so for tremor, you may use a medication such as Klonopin in low doses. Again, the beta blocker, propranolol, has been used for the myoclonic movements. There are a number of medications that have been tried and with no great benefit or improvement. Tim Benke in Colorado has a very interesting protocol where he treats individuals with increasing rigidity with the Parkinson drug, L-Dopa, carbidopa, and he says that he has seen improvement with it. But again, to engage in this, you need to see an expert in movement disorders. You know, it's a tough question, because if a girl is at home and everybody has their own lives, and you got to do things. You can't just spend all of your time with your older daughter. So the lack of socialization and interaction, they just get quiet. They may sleep or nap excessively or more than they did as a child, and their peer interactions have gone away. So the best advice I can give is to be certain that your daughter has a variety of things she can do during the week that aren't dependent on you, and hope for the best. I think that in general, we have a couple of young 20-ish-year-old women who get together with their high school classmates once a year. And the change in those girls, the parents, I haven't been there, but the parents say it's remarkable how they are energized by that. So it's just the issue of socialization is critical. We do know from studies and in animal models of Rett syndrome that environment, or the change in environment, is so critical for the advancement or maintenance of normal function or near normal function in these girls.
Thank you. So Dr. Percy, I think, would we take that as your closing thoughts? If you could pick the one thing that parents could do to optimize quality of life, to improve longevity, would it be fair to summarize that socialization, engagement, changing of routine, maybe not spending all of their time with their aging parents, if possible, letting them have time with age-related peers, That's really those quality of life issues, as well as addressing medical issues. So if you are feeling that there is a medical issue that is true pain, that is different than what her baseline is, that don't let someone just dismiss it's a Rett thing. Go do the due diligence, have some assessments and interventions done. That between that, getting the proper medical care and addressing quality of life.
I agree with that.
Is that a good summary?
Yep.
Okay. So in other words, we are dealing with human beings who are very active, very responsive to the environment around them, very responsive to good quality medical care. And we have seen dramatic change in longevity over the decades as medical care has improved, as recognition of communication and socialization has been identified, and we're getting education, we're getting day programs. We've seen a direct would you say a direct correlation in longevity?
I would agree.
Okay, so we are not dealing with a syndrome that is degenerative.
Correct.
Okay, and that is, I think, a great statement to end on. We still, unfortunately, find information on the internet and some clinicians giving the parents of our children the message that this is a degenerative disorder. And we are finding both in males and females that that is not the story to be told.
Correct.
Okay. All right, we've gone a little bit over your time. I know you have a patient waiting, so thank you very much for being with us today. We look forward to having you back again.